Welcome back to our 11th telethon for stroke and aphasia awareness. We are very, very pleased to have Richard Libman, Dr. Richard Libman, with us again. He will be speaking. Well, first, let me introduce him. He is the Vice Chair of Neurology at LIJ, Co-Director, Stroke Center, Professor of Neurology, Zucker School of Medicine at Hofstra Northwell. He's going to speak to us a little bit now about treatment for ischemic strokes, where there is a mechanically now able to go in and pull out a large blood clot, but now there is some continued additional treatment that is giving us even better results. Dr. Libman, take it away.
Thank you very much, Ginny, and it's a pleasure to be back. And now I'd like to cover the topic of mechanical clot retrieval, that is, pulling clots out of major blood vessels in the head, which are blocked, which cause the most devastating and the largest types of strokes. And they're really quite common and something that we now deal with day in and day out. So just again, to give you the context and the historical kind of perspective, more than 30 years ago, we had essentially nothing to treat stroke with. Essentially nothing when a patient would come into the emergency department. Then in the mid-1990s, the clot-busting drug TPA was approved by the FDA after several years of really intensive study, and that immediately revolutionized treatment of stroke and resulted in better outcomes for the first time, I would guess, for the first time in thousands of years. You know, stroke is even described in the Bible, and you'll see it in the Old Testament. And I don't know if you're aware, but there is an ancient prayer that says, if I don't do such and such, or I don't pray, or I don't believe in God, I'm sorry, this is kind of a digression. May my tongue cling to the roof of my mouth, which almost definitely means slurred speech, and or unable, some kind of speech difficulty, and my right hand lose its function. Those two were combined, speech disturbance and right hand losing its function. And as many of you will know, and again, this is so sorry, a wild digression, but I can't help myself. As everybody knows, or many people know, the left side of the brain is involved with language. The left side of the brain controls the right side of the body, and one of the most common stroke types and stroke scenarios we encounter is a language problem, speech problem, and right-sided weakness. And there it was in this prayer that's more than 2,000 years old that said, if I don't follow your commandments, O Lord, may my tongue lose its function, may I have a speech disturbance, and my right hand lose its function. I'll develop weakness on my right side. So that's why I'm saying 1996 was the approval of TPA after about 6 years of a clinical trial that we were very, very involved with at Long Island Jewish Medical Center, part of Northwell, where I am. I have to say it because I'm very proud of it. And we were very involved with that study. And that's why I say maybe it was the first treatment in 2,000 years, not just the last 30 years. So TPA, or clot-busting drugs, revolutionized. I have a little visitor here you may just see on the top of the screen. It's hard for me to be too forceful with him because he'll just come back. So I let him do his thing. He'll walk across a couple of times and then he'll go find something else. That's Freddie. The next major innovation in stroke treatment was what we were talking about right at the onset, which is so-called mechanical clot retrieval. A certain percentage of strokes, maybe 20%, are due to blockage in a major blood vessel in the brain, not a branch that goes further out that's somewhat smaller, or tiny little branches or little blood vessels, but rather the major blood vessels. And what was known from the very beginning when we developed TPA as the first treatment was that the outcomes with TPA, when the blockage was in one of these major large blood vessels, the outcomes weren't as good. Some patients got all the way better. Many patients only got partially better, and a fair fair number did not improve. And it's probably because when we give clot busting drugs like TPA or tenecteplase, now used a little more commonly, but same idea, basically cousin medications or sister medications, TPA or tenecteplase, you give it into the vein, it circulates through the body, it gets up, through the heart, gets pumped up, goes into the brain, goes to the blockage. But by the time it gets there, no doubt you've lost a lot of the concentration of the medication. And it's very hard for clot busting drugs like TPA or tenecteplase to reopen these major blockages in very large blood vessels. So some people get better, some people don't. That's really what led to the innovation of going in with a catheter, usually through the groin, the same way you do a cardiac catheterization, heart catheterization that many people are familiar with. You make a little puncture in the groin, you go in with a wire, goes all the way up. For cardiac reasons, it'll stop here, and you inject dye, or you put stents into the heart blood vessels. For brain reasons and stroke reasons, you keep going, and you can go up into the carotid artery, and then you can keep going up to the carotid artery. Carotid artery goes now into the head, basically where the brain is, and then the carotid artery gives off one of its major branches, and that's the one that's commonly blocked. And that's the one where the conventional clot busting drugs don't do such a great job. You can go all the way up with this catheter, go into that major branch of the carotid artery or the carotid artery itself, grab hold of that clot and pull it out. And it sounds so primitive in a way. I don't know. It sounds kind of not very sophisticated, going in and sort of grabbing a clot and just mechanically pulling it out. But of course, the devices themselves are anything but primitive. They're designed, after years and years of testing and this and that, to be the safest and most effective types of devices to go in, pull out these clots. There are multiple different types. And the results from pulling out those clots are dramatic, with a huge percentage of patients getting better, many all the way better, so that they don't even have to go to rehabilitation after their hospitalization. They can often just go home. Basically, it converts, if you want to look at success rates, maybe, let's just say 30% of people might get all the way better just by medical treatment, giving them medications and that kind of thing. Sometimes you give them clot busting drugs, then you can maybe get 45% better. With this mechanical retrieval of clots, you can make up to 70% of people better. In some studies, even 80%. Okay, full disclosure, some studies maybe only 60, 65. There's always a range because there are different studies. There have been so many studies done all over the world. So you get a range of results. It depends on just who's treating, what the patients are like, what country, what the other standards of care are in various countries. But you certainly dramatically increase the number of people who basically can get out of bed the next day, walking around, functioning, independent, and can go home. It is dramatic. And it's been compared to other types of treatment. You can compare it to other types of treatment in medicine. Antibiotics for, bacterial infections, surgery of various types, to taking out your appendix, other forms of medical treatment for all kinds of conditions, cancer, you name it. Mechanical retrieval of clots, when you look at how powerful it is in terms of helping people get better, is considered among the most effective treatments in all of medicine. Not, not just stroke, not just neurology, all of medicine, all fields. So, excuse me, I'm trying to make the point that this was the next major innovation in stroke treatment following the advent of TPA. And it is really impressive. I can't emphasize it enough. Now, having said that, there's always a but or a caveat. The question is, if we are so effectively pulling out clots, here comes number 2 on my other side, Freddie on my left, Fitz on my right. If you see orange or black fur going across the screen, you'll know why. And he's going down, so that's not a problem. Basically, if we're so good at pulling out clots, virtually 100%, 90%, 95%, How come only 60 or 70% or maybe 80% are doing well? Why? There may be lots and lots of explanations, but why aren't we making 90 or 95%, if not 100% of our patients completely better when we are clearly restoring blood flow and we're doing it quickly? And yet they're not all getting better. They're not all bouncing off the bed and starting to dance the next day and that kind of thing. Again, there may be multiple explanations, but one explanation may be that aside from that major clot that's causing a problem, it may be that tiny little particles, maybe a little piece of blood clot, maybe little pieces of plaque or hardening of the artery, something is migrating and moving from that major blockage down to these tiny little branches going down further downstream in the brain. Just as you get, one big river and then it splits into these little, or not tributaries, but these little streams that are coming off the river. Maybe I may be not making a very good analogy, but they're all going off in different directions and the river has stopped. But all these little streams are continuing, little branch points. And many people think that aside from that major clot, tiny little, even microscopic clots we cannot see, even doing the most sophisticated testing and our angiograms, catheter-based, angiograms where you inject dye and take pictures, you may not see these tiny clots, but they may be blocking much, much smaller blood vessels downstream. So that after you've opened up this major artery and you've pulled out this clot, and you say there should be 100% better, it may be that there's multiple little tiny areas of brain that are still blocked, although we can't see the blockages because they're too small. So some great investigators had the idea which it was, after pulling out the clot, what if we keep a catheter right in the brain, in the blood vessels, the big clot is gone, and then use that little catheter to inject directly into the blood vessel and going downstream into these little branches to inject a clot-busting drug, like TPA. We give TPA by the vein, we give tenecteplase by the vein, but as I mentioned in the other talk, that circulates throughout the body. By the time it gets up to the brain, it's there, it's doing its job, but it's been diluted. It's circulated all over the place. Somebody thought, well, if we already have a catheter in there because we've already pulled out the clot. We don't have to start the process all over again. It's already done. Pulled out the clot, catheter's there. Let's see what happens if we now inject a small amount of clot-busting drug, such as TPA or tenecteplase. And will that make a difference? Maybe if there are tiny little blood clots which have migrated into these tiny little branches, even though we can't see them, if we can break up those little blood clots, maybe we'll restore even more circulation to the brain than we're doing just by pulling out that major clot. And lo and behold, there are now several large studies, randomized trials. Some patients just get mechanical clot retrieval, pull out that clot. That's it. That's standard of care. Many of them get better, but not all of them. And then half of the patients getting the same procedure, pulling out the clot, but then taking that extra step, injecting a clot-busting drug directly into the brain artery, letting it go downstream, sort of go out further into those tiny branches. And lo and behold, several studies have now shown even better outcomes. Remember, the outcomes are dramatic to begin with, but they're not perfect. There's no such thing as perfection, I don't think, in most areas of medicine, and stroke's been one of the hardest nuts to crack. Well, this was another chink in the armor, you might say, of stroke treatment, improving yet further on an incredibly powerful technique, which is mechanically pulling out the clot. Further improvement by injecting clot-busting drug directly into the arteries. That's called intra-arterial, in the artery. But it's no longer pulling out anything, it's putting in the clot-busting drug right where you want it to go. So that is another treatment type of strategy, which is pretty hot off the presses, published in the last year, even in the last 6 months, and showing a lot of promise and may well become the standard of care. You know, everything takes a little time to trickle down after you get studies done and has to be presented at these big national conferences and published in journals. And slowly but surely it percolates into the whole community of stroke clinicians. And then it starts to get used more and more. And I think that's what's going to happen. So that is probably not kind of a huge revolution in stroke treatment, but you might call it something that's added to stroke treatment and will enhance stroke treatment of the largest types of strokes and the worst types of strokes.
It's very encouraging to hear that kind of news, really, that so many more people will have so much better function and outcome from a stroke like that. Now, is this procedure being done at LIJ or at
Great
Northwell
question,
now?
Ginny. Is it being done? The answer is yes and no. I say yes because it's being done at the discretion of the interventional clinician who's actually doing the procedure. And so that means it's right now a little bit not random, but basically at the discretion of the clinician, thinking that this is the right thing to do. And what tells the clinician it's the right thing to do? Well, that's their clinical judgment. It's not being done uniformly. It's really not being done uniformly anywhere in the world as yet, not consistently. It's that new, Jenny. It really is that new. I'm not saying it was yesterday, but it's analogous to TPA being approved, on November 2nd. Is everybody going to use it on November 3rd? No. A, they probably don't even have the drug yet, and B, they're not experienced yet, even though the data are there, the science is there, the research is there. So it has started to be used, and I've seen it used, and the patients it's been used on have done very well, but nothing is perfect. And again, it is so new from the research community percolating into the clinical community, sort of diffusing. And eventually, of course, it will probably have to make its way into so-called national guidelines. As you may know, the American Heart Association, the American Academy of Neurology, other big organizations publish national guidelines every year, or every 2 years, or every 3 years, meant to guide clinicians. In this situation, what do we recommend? That's a guideline. And they've synthesized and analyzed every study done, everything published, everything in the literature, put it together, looked at risks and looked at benefits, and then finally settle on a recommendation, a strong recommendation, a weak recommendation, maybe the recommendation do nothing, etc. But eventually it gets into national guidelines. And once that happens, Ginny, that's when things tend to take off a little bit faster. For example, a newer sort of innovation, a newer strategy like this, the main treatment still being pull that clot out mechanically, and then sort of a secondary treatment, sort of gilding the lily, making it even more beautiful, but in a positive way, to add a little bit of extra benefit to that treatment. So not widespread at the moment, but starting to trickle in terms of treatment.
Very good. Thank you so much, Dr. Libman. Again, it's a pleasure always to have you here and to bring your wisdom and bring your good news to us all the time. Thank you so much.
My pleasure, as usual, Ginny, and it's always a pleasure to be here and to speak to you.